Can you hear me well? Yeah. It's my pleasure to present this topic on next generation biomarkers for patients treated with ICIs. Here are my disclosures. So immunotherapy has radically changed the therapeutic management of patients with non-small cell lung cancer, yet only a subset of patients do have clinical benefit, and there is a high need to identify biomarkers in order to better select patients who will benefit from immunotherapy. All three, PD-L1 tumor expression, mismatch repair deficiency, and TMB biomarkers have predicted outcome with PD-1 inhibition. Yet PD-L1 tumor expression is the only predictive biomarker daily used in clinical practice for patients with non-small cell lung cancer. Its limitations, here, for example, the intratumoral heterogeneity and variability between immunohistochemistry assays. Mismatch repair deficiency, not exported in patients with non-small cell lung cancer, has predicted outcome with PD-1 inhibition. One of its limitations is, for example, the POL-E mutation that may test positive high for MSI high, but negative for mismatch repair deficiency. Tumor mutational burden, defined as the number of somatic mutations, have predicted outcome with PD-1 inhibition across all tumor types, independently of the PD-L1 tumor expression. Yet the main limitation for TMB is the lack of standardized thresholds. In patients with tumor with non-small cell lung cancer, increasing TMB levels are associated with immune cell infiltration and inflammatory T cell response, resulting in increased sensitivity to immunotherapy. So we need next generation biomarkers in order to improve patient selection, avoid toxicity in non-responders, and this is a high unmet need in order to find robust biomarker. The recent example of TIGIT with positive phase 2 and 2 negative signals in phase 3 trials, possibly due to the lack of biomarker, is one of the main reasons to redefine biomarker-based trial strategy. So far, biomarker FDA approved are PD-L1 tumor expression, MSI, and TMB, and current biomarkers are being explored, will be categorized into three parts: tumor, host, and microenvironment. First, we discussed the volumetric tumor-related biomarker with tumor burden assessed by simple tools useful in clinical practice. Indeed, large BTS, baseline tumor size, defined here as sum of longest diameters, was associated with worse outcome in patients with non-small cell lung cancer treated with atezolizumab. Furthermore, the presence of bone metastasis here remains significantly associated with worse OS, PFS, and overall response rate. What are the emerging biomarkers tumor-related? Regarding volumetric, we'll discuss two multimodal model biomarker. Using deep learning model, two presentations at ASCO this year, one with CT deep learning model, then integrating clinical and pathology features, was associated with PFS and OS in patients treated with immunotherapy, differentiating low-risk and high-risk patients. Another multimodal biomarker integrating radiology, pathology, and genomics was also predicted for immunotherapy response. Regarding the tumor-related genomics biomarker with the identifications of mutations associated or not with outcomes, recent presentation at ASCO showing that KRAS has probably no impact on efficacy outcomes of chemo-IO or IO alone in frontline, and STK11 deletion associated with low response rate with immunotherapy and short PFS among KRAS mutation. A recent publication with POL proofreading deficiency leading to high TMB and high TILs that we'll discuss later could represent a novel tissue-agnostic biomarker for immunotherapy. The mechanism of resistance of immunotherapy are also being explored with the identification of mutations with STK11, KEAP1, SMACR4, B2M, and generally, the molecular alterations are less common in patients with durable benefit after starting immunotherapy. Emerging biomarkers tumor-related are also circulating. We just discussed, for example, blood TMB, yet here associated with better OS, but it was a secondary endpoint, and it's still a weak biomarker today in liquid biopsy, minimally invasive access to blood tumor TMB. Circulating genomic alterations with the identifications from cell-free DNA co-mutation STK11 and KRAS were associated with worse outcome to immunotherapy. ctDNA might be a useful tool to guide patient selection and help disease monitoring in patients treated with IO or IO plus chemo. Here, elevated tumor fraction, elevated tumor fraction, ctDNA, identified increased risk of early progression on immunotherapy for patients with non-small cell lung cancer here at the left of the slide. Undetectable ctDNA from the NADIM trial neoadjuvant was associated in the blue curves with better OS and PFS. So ctDNA might be a biomarker to predict early progression, but also early response on immunotherapy with the monitoring of rapid decrease in LL fraction. Regarding the host-related biomarker, we'll discuss clinical ones and then the biological scores. Regarding the clinical ones, we all know that poor PS, or ECOG-2-3, at the time of initiation of immunotherapy is correlated with worse outcome. The use of concomitant medication associated with worse outcome here with antibiotics and steroids in non-small cell lung cancer patients cohort here with the two first antibiotics and steroids, and with the use of acetaminophen recently published by Antoine Italiano was correlated with worse OS due to increase of Tregs across all tumor types. Regarding the biological scores, pre-LIPI score combined as the DNLR above 3 and LDH above normal, identifying patients into 3 groups, good LIPI, intermediate LIPI, and poor LIPI, is a useful tool to better select patients using immunotherapy. Regarding DNLR changes, Laura Mesquita also demonstrated that patients who went from low to low or high to low, the changes is associated with better outcome. Regarding the emerging biomarkers host-related, we'll discuss one multimodal biomarker and the promising biomarker microbiota. Using machine learning, the integration of low NLR, decrease in NLR, and high eosinophil percentage changes was associated with clinical benefit in PFS, OS, and MPR. Microbiome is a promising biomarker being explored in different tumor types. And here, a work from Lisa De Rosa showed that only in patients with non-small cell lung cancer, at the left of the slide, that the abundance of Akkermansia mucinifila predicted clinical response to PD-1 inhibitors. Eduardo Klein presented at ASCO that there is a correlation between LIPI score, microbiome, and immunotherapy outcomes. Indeed, patients with good score LIPI had favorable microbiome and favorable OS. Regarding the microenvironment biomarker, serum analyses and immune cells will be discussed, with serum analyses such as elevation of CRP, inducing PD-L1 expression, being potentially an indirect biomarker for immunotherapy response. The elevation of interleukin-8 was associated with poor outcome for patients with non-small cell lung cancer treated with nivo plus without ipilimumab. High TILS levels were associated with survival, and TILS was superior to TMB in PD-L1 non-small cell lung cancer patients. CD8 positive T cells, being the most abundant subset of TILs, was associated with better outcomes when high in the blue curves, only in PD-L1 high patients. So what are the emerging biomarkers in microenvironment? We'll discuss various ones and begin with the immunoscore that has already been explored in colorectal cancer. At ASCO this year, Gallo and his team presented his work on in patients with non-small cell lung cancer as being a potent tool to predict the efficacy of immunotherapy. It's an in vitro FFPE test using digital pathology again with duplex immunohistochemistry, CD8 and PD-L1 staining, differentiating patients into high risk and low risk. And here, 1% of patients with high risk relapse in less than 18 months versus 30% patients in low risk under immunotherapy only in patients with non-small cell lung cancer. Secondly, the predictive value of tumor-activated macrophage with low CD1, 60% positive infiltration, below on the slide left, being associated with better outcome. Up in the slides, we see again with the CD8 positive high in the red curves associated with better outcome as we discussed already. And in the right slide, the high SF1R associated with longer outcome, which is expressed in the M1 macrophages. The extracellular vesicles, EV, are involved in the TME and have a role in tumor progression. The expression of PD-L1 in AV from plasma and its dynamics are helpful to guide the use of immunotherapy. On the last slide, the EV PD-L1 decrease was associated in patients with non-small cell lung cancer with immunotherapy response, in the middle immunotherapy and chemo, and on the right, no evidence of clinical benefit under chemo alone. Whole CIP, circulating immune profiling, might be a biomarker to predict immunotherapy response also. It's a biomarker that is counting absolute cells from innate and adaptive subsets, differentiating patients into higher or poorer baseline subsets and associated with outcomes. It's a next-generation immune biomarker that could be useful to identify patients who will benefit from immunotherapy, here pembrolizumab in patients with non-small cell lung cancer. GES, gene expression signature, has to be further explored in patients with non-small cell lung cancer, as we know its prognostic value, but we have poor data on the biomarker value. And at ASCO this year, across all tumor types, GES 12-gene classifier was associated with immunotherapy benefit. Last but not least, the TLS, tertiary lymphocyte structures that are ectopic aggregate cells from an inflammatory reaction enriched in B cells, T cells, and DCs, is associated across different cohorts, non-small cell lung cancer here, and melanoma and sarcoma, with increasing B cells, increasing TLS, and gut microbiome signature. In patients with non-small cell lung cancer, responder to immunotherapy, it has been shown the abundance of bacteria Ruminococcus and the increasing B cell signature by work from Elise Nassif at ASCO this year. Using digital pathology to identify TLS helped also the identification and demonstration that high TLS is associated indeed with better outcome. So TLS is a very promising biomarker which is being explored in other tumor types such as sarcoma with the recent publication of Antoine Italiano and melanoma. So here is a resume of the next generation biomarker, tumor-related, host-related, and microenvironment. And the next step is that we should be guiding patients into targeted or personalized immunotherapy through AI model, either tumor, host, or microenvironment from tissue, blood, and fecal samples. And the challenge is now to implement multiple features into multi-biomarker based clinical trial in order to better select, identify, and guide patients who will highly benefit from immunotherapy. Thank you for your attention.
Thank you very much. So it's a pleasure to be here in Milan, and thank you again to Filippo for inviting me. And I couldn't agree more with Anne-Marie's conclusion about the fact that we need personalized treatment and very much a multidisciplinary team making decisions. So I've been asked to talk about local regional treatment. So these are my disclosures. So I had to choose what to talk about, so I can't cover everything because there's so much to say. So I'm going to start with a little bit on early stage non-small cell lung cancer and then move on to the most important part, which is the locally advanced non-small cell lung cancer with the role of immunotherapy, of course, and some new data on post-operative radiotherapy. So I am going to present, hopefully, some recent data from this year. A lot of it is still a bit controversial and talk about future directions, particularly with regards to the topic of where does chemoradiotherapy fit in. Now we have all this data on adjuvant, neoadjuvant immunotherapy and chemoimmunotherapy. I'm only going to focus on non-small cell lung cancer because I don't have time. There would be a lot to say in the small cell setting, but I do not have the time to do that. So let me just start with early stage non-small cell lung cancer. So we have about 20% of patients who present with stage 1 disease, and that is likely to increase dramatically in all of our countries. I mean, certainly in the UK, we're now implementing screening, so I think that group of patients is going to increase rapidly in the next few years, and hopefully we'll see less patients with stage 4 disease. It is clear that the standard of care, if a patient is operable, is surgery, but at least 1 in 3 patients are not suitable for surgery, either because they're medically inoperable, and that is the majority of the patients, certainly I see in my clinic, but some patients are operable but will refuse surgery, for example, if they're elderly. So stereotactic ablative body radiotherapy is an alternative to surgery. We can achieve excellent local control rates, and the toxicity is very, very minor in the majority of patients. However, what is important is that despite the fact that these patients have very early stage disease, the risk of distant metastasis is between 10 and 20%. And that is something that we've not been able to deal with. We know that the majority of patients having SABR are elderly, they're frail, they would not tolerate adjuvant chemotherapy, which is not considered in this group of patients, and we do not have any evidence. So with regards to SABR, so for those of you, I'm sure most of you in the audience will be medical oncologists, so SABR is the delivery of high precision radiation, very conformal plan with a very steep dose fall-off, so very little dose delivered beyond the target, very high dose per treatment and delivered in a small number of fractions. So nowadays, for example, in a tumor that is within lung tissue, away from central structures, away from the chest wall, we can even give 1 fraction of radiotherapy, which is extremely convenient, as you can imagine, particularly for very old and frail patients with low levels of toxicity. Up to 2019, actually, we did not have evidence of the efficacy and impact on survival and freedom from local failure of SABR versus conventional radiotherapy. But we now have that evidence from the study published in the Lancet Oncology by David Bull et al., comparing SABR, you can see there were different dose fractionations that were permitted, versus more conventional radiotherapy, either delivered with 2 gram per fraction or more hypofractionated radiotherapy. And you can see this big difference with a reduction in the risk of death of 47% with SABR compared to standard radiotherapy. Now, a big question that still remains is very much the question of, is SABR safe in tumors that are central or ultracentral? And you can see that there are 2 definitions of central. The first one on the left-hand side, which is the RTOG definition, so tumors within that no-fly zone, which is within 2 centimeters of the central airways, and then a new definition that was published in 2015 from ESMO, which defines central tumors as tumors within 2 centimeters of any sort of mediastinal structure, which I think makes a lot more sense. So we have a study from the RTOG that has defined a dose fractionation of 60 grain 5 fractions, and then in Europe we tend to use more 8 fractions regimens. But what is important is that in the ultracentral tumors, so the tumors that are located really close to the main bronchi or the lower part of the trachea, there have been reports of very severe toxicities, as you can see from the paper in the New England Journal of Medicine, some necrosis of the airways, and then in a paper from the Netherlands, in ultracentral tumors, 15% of fatal pulmonary hemorrhage. So we're still very cautious in this specific group of patients with regards to the use of SABR. And then what is important is that, as mentioned before, there's a high risk of metastatic disease in this group who have early stage disease, and there's a very nice abstract that was presented, but I have not actually seen the full publication, showing that, of course, as the tumor size increases, there's an increase in the risk of local failure and distant failure. The majority of failures are within the first 2 years after SABR, and the majority are actually distant as opposed to local regional. As mentioned previously, chemotherapy would be considered to be too toxic in this population, and we know that IO alone has a tolerable toxicity profile, including in elderly patients, so there's certainly a rationale for adjuvant immunotherapy in this group of patients. And as you can see from this table, there are quite a number of ongoing trials. Majority are phase 2 studies, some are single institution. There is one randomized phase 3 trial, the Pacific 4 study, that is adding durvalumab after SABR. Some of the other studies either add the immunotherapy agent to SABR and also during the consolidation treatment. So that is very much awaited. I'm now going to move on to the locally advanced non-small cell lung cancer setting. And in this setting, really, what we want to achieve, let me just clarify that I'm talking about unresectable stage 3 non-small cell lung cancer. So with the chemoradiotherapy combination, we're aiming to achieve this balance between optimal local control, but at the same time, we want to minimize side effects as much as possible. We know that local relapse it remains a big problem despite advances in our chemoradiotherapy treatment, but most importantly, again, similarly to the early stage setting, metastatic relapse is a big problem with approximately 50% of patients having metastatic relapse at 2 years. And with a drug radiotherapy combination, what we want to do is to modify that therapeutic window in order to improve both local control and survival. So there's therefore a very strong rationale to combine and optimize drug radiotherapy combination, including, of course, immunotherapy. So this slide summarizes the standard of care in inoperable stage 3 non-small cell lung cancer pre-immunotherapy era. So the standard of care was concurrent chemoradiotherapy, and we learned from the seminal RTOG0617 study that there is no role for dose escalation using conventional fractionation, and this study has defined what we consider to be the international standard of care of 60 grain 30 fractions combined with chemotherapy. Another really important message, which I will come back to from RTOG0617, is the importance of a radiation dose to the heart. And it was defined for the first time that actually above a certain threshold, the more patients are dying, and are dying actually quite early, probably of cardiac complications. In terms of the chemotherapy treatment, so we give cisplatin-based chemotherapy, either carboplatin or cisplatin-based. We've learned over the years from many randomized trials that there's no role for either induction or consolidation chemotherapy. And to this date, there is still no defined role for targeted agents, including in patients who have driver mutations. So we've been going round in circles for many years in terms of defining optimal radiotherapy treatments and defining optimal chemotherapy to combine with radiotherapy until the Pacific study, which was defined as a tsunami in the field of thoracic oncology and became a standard of care. So there is a strong rationale again for combining immunotherapy and radiotherapy from preclinical data. So we know that radiotherapy potentiates the anti-tumor immune response through a number of mechanisms that are summarized on this slide. But what we know is that the microenvironment is also very immunosuppressive and will dampen down the immune response, for example, through the interaction between the PD-1 and the PD-L1 receptors. So hence this investigation of immunotherapy in addition to radiotherapy. So just a reminder, many of you will be obviously very familiar with the Pacific study, which included unresectable stage 3 non-small cell lung cancer without progression after definitive platinum-based chemoradiotherapy, at least 2 cycles. The patients also had to have recovered from the side effects of chemoradiotherapy. It's important that to say that it's an all-comers population, so the pre-chemoradiotherapy tumor tissue was not mandatory to be provided in this study. And patients within 1 to 42 days after chemoradiotherapy were randomized 2-to-1 between durvalumab every 2 weeks for up to 12 months versus placebo. You can see the stratification factors, and there were 2 co-primary endpoints, progression-free survival and overall survival. So what is important is that we now have quite long-term data on both PFS and OS. So the 4-year survival data, so reduction in the risk of death of 29% and reduction in the risk of death or progression of 45% with the addition of durvalumab after chemoradiotherapy. And then these figures were updated again at 5 years and published recently in JCO. So you can see this very prolonged benefit in terms of addition of durvalumab and a difference at 5 years. So 42% 5-year survival with durvalumab versus 33% with placebo. Another aspect that is extremely important is that we were all very concerned about the risk of pneumonitis after chemoradiotherapy when adding immunotherapy. That was not the case. The rate of grade 3/4 pneumonitis was less than 4%, which was very reassuring. Now, in terms of subgroup analysis, most subgroup benefited at the exception of 2 subgroups, so patients with EGFR mutations, and I'll come back to that in a minute, and also patients with a PD-L1 of less than 1%. So as mentioned by Anne-Marie, the EMA does request unplanned analysis, and this was the case. The pre-specified analysis was with cutoff of 25%. This was unplanned, but as you can see from the bottom here, no benefit in the less than PD-L1. So that led to actually a differential approval in different settings. So for example, in the US, the FDA approved durvalumab for all comers. In Europe, that wasn't the case, and certainly not in the UK. The approval is in PD-L1 of more than 1%. Also important to note that EMA and FDA approved durvalumab in patients who had received chemoradiotherapy. It wasn't actually specified it had to be concurrent chemoradiotherapy, but for example, in the UK, NICE has only approved the drug in patients who receive concurrent treatment, so we cannot prescribe it, for example, in patients receiving sequential chemoradiotherapy. Now, this is the post-hoc analysis presented at ASCO this year by Dr. Naidu in the patients with EGFR mutation. So as you can see from the PFS and overall survival curves, the outcome with durvalumab was similar to placebo, but with very wide confidence interval. Importantly, to consider that the safety data for durvalumab in this EGFR mutated subgroup were consistent with the overall population, so no difference there. But we have to be very cautious, of course. We're talking about a very small population, 35 patients out of 713 patients, imbalances in baseline characteristics between the treatment groups, and clearly this trial was not designed to evaluate clinical outcome according to EGFR mutated biomarker status. Now, the ESMO published this expert consensus statement on the management of EGFR mutant non-small cell lung cancer, which I had the privilege to be involved with. And there were 2 important questions that were asked in this group of patients. So in patients with EGFR mutation, inoperable stage 3 non-small cell lung cancer undergoing curative intent chemoradiotherapy, what is the role of consolidation immune checkpoint inhibitor therapy? And this is what the group concluded. In this group, the use of consolidation ICI therapy after curative intent chemoradiotherapy is not recommended. The second question is in patients with inoperable stage 3 non-small cell lung cancer with an EGFR mutation, what is the role of TKI pre, post, or during radiotherapy? And again, no role in this setting, which we discussed a little bit yesterday afternoon. Now, new data that was presented by Marina at ELCC this year, and the paper has been submitted, is on the Pacific 6, so in patients who have sequential chemoradiotherapy. And I understand that in Italy, similarly to the UK, you prescribe quite a lot of sequential chemoradiotherapy still in patients with unresectable non-small cell lung cancer, as you have many patients who are elderly and frail. This study is not randomized, so it's a single-arm, multi-center study where patients who had sequential chemoradiotherapy went on to having durvalumab for up to 24 cycles. There were 2 cohorts of patients, one with good performance status 0-1 and another one with PS2. And it was foreseen to include up to 30 patients in that PS2 cohort. So as you can see, and not surprisingly, the majority of patients were above the age of 65. Very few patients actually were enrolled in the PS2 cohort, only 2.6% of all of the patients. The majority of patients had stage 3B disease. Majority had adenocarcinoma, and important to say that the PD-L1 expression level was not available in 40% of the patients. 117 patients were enrolled, and the number of prior cycles of chemotherapy was 4. Most patients had 60 gray, and the time from radiotherapy to durvalumab start was a median of 26 days. If we look at a median total treatment duration, it was 32 weeks, and as you can see at the time of the presentation, some patients, so almost 40%, were still ongoing treatment. The main reason for discontinuation of durvalumab was progressive disease and adverse events in 21% of patients. The primary endpoint of the study was the incidence of AEs that were possibly related to the treatment. And as you can see, there were 5 patients who developed grade 3 to 4 possibly related adverse events to treatment within the 6 months of starting durvalumab. So the incidence is 4.3%, which is very reassuring in this group of patients, and you can see what these events are. One patient died as a result of treatment, and 16% had adverse events leading to treatment discontinuation. In terms of efficacy, the PFS and OS, you can see at the top, compare favorably to historical cohorts treated with sequential chemoradiotherapy, in which most patients progress within a year. So if we take that together with the fact that durvalumab has a similar safety profile to that observed with durvalumab after concurrent chemoradiotherapy in the Pacific study, I think this is quite encouraging data. And we have a Pacific 5 study that is going to report soon, hopefully, that has been assessing the efficacy and safety of consolidation durvalumab in either concurrent or sequential chemoradiotherapy setting. So this slide summarizes progress made in 4 decades, all the way from radiotherapy alone in the 1980s, and then with better integration of chemotherapy and radiotherapy, particularly with the concurrent integration, also some improvement in radiotherapy techniques such as IMRT, and then finally to the addition of durvalumab, we've gone from 10% 2-year survival all the way to 66% 2-year survival, which I'm sure you will agree is major progress. We have many trials ongoing. I've not had time to show you this with other immune checkpoint inhibitors. Obviously, durvalumab is the drug that is approved, but many others are ongoing and will have results soon. And there are also a lot of unanswered questions around the duration of consolidation immunotherapy, the timing of chemoradiotherapy and consolidation immunotherapy, and many more. So I'm looking forward to hearing more on that. Now, I'll quickly tell you about the long-out study, which is data that's been published by Cécile Peychoul this year in Lancet Oncology. So in this study, patients with completely resected stage 3 disease were randomized 1-to-1 between control and post-operative radiotherapy. Primary endpoint was disease-free survival. And you can see that there was a non-statistically significant 15% increase in DFS, but the p-value was 0.16. Now, the 3-year disease-free survival was higher than expected in both arms, and I think that reflects on the quality of the surgery and the radiotherapy in this study. Now, what is also very important is that the mediastinal relapse rate was reduced very significantly with PORT, so it's important to acknowledge that almost 50% of patients had mediastinal relapse in the control group versus 25% in the PORT group, and you can see the overall survival, no difference at the bottom, but also, again, very, very good overall survival at 3 years, which is important to keep in mind. What Lungout has also highlighted, and I'll come back to what I said about RTOG0617, is the importance of the radiation dose to the heart. There were more cardiopulmonary deaths in the radiotherapy arm, 16% versus 2% in the control arm, and more toxicity, of course, overall. So the conclusion is that conformal PORT cannot be recommended as a standard of care in all completely resected patients, but bearing in mind this very high relapse rate in patients who do not receive PORT, so there's probably a need for postoperative surveillance. There are still some questions, for example, in patients with extracapsular extension. And we have, as I said, excellent survival in the control arm, and really we have this debate that remains between a surgical versus a non-surgical treatment, particularly in the IO era, and the importance of limiting radiation to the dose of the heart. So there's a lot of research ongoing, including in my institution, where we're now implementing dose limit to the base of the heart, and we're doing that in a very systematic way in the setting of the national program grant. Now, Anne-Marie asked the question earlier, so what is the view of a radiation oncologist? And I think we have to now bear in mind that we are in an evolving era of adjuvant and neoadjuvant chemo-IO with examples that were given by Anne-Marie. And I think really now the time is ripe to think about studies comparing a surgical to a non-surgical approach in the immunotherapy era with primary endpoints of PFS, OS, but also very importantly, I think quality of life needs to be considered, and patients' preference also needs to be taken into account when thinking about various strategies. In the UK, we have a feasibility study that is recruiting, that is comparing a surgical to a non-surgical approach, but that is only a feasibility study. We're hoping that this would lead to a larger phase 3 study. And these are my conclusions. So for the early stage setting, in terms of systemic treatment, there is no role yet for immunotherapy in this setting. Clearly, it is the case in the non-small cell unresectable setting. Metastatic and local control remain a challenge. We clearly have a complete landscape that is changing all the time. Consolidation IO is the standard of care. There is no role for PORT after complete resection in the routine setting, and there's a real unmet need to compare a surgical to a non-surgical approach in the IO era. And the key message, as always, is please enroll patients in clinical trials so we can have the evidence to treat our patients in the optimal way. Thank you for your attention.